Good evening, everyone, and welcome. Thanks very much for joining Susie and myself and Joe for this last webinar in our series. Just briefly, a little bit of background on CornerStones, which Susie and I have had the privilege of being involved in for several years. It's a not-for-profit medical education company that our role is to summarise the best and clinically most relevant research in inflammatory bowel disease each year from DDW. It's a global faculty of 40 IBDologists, each working with an advanced IBD fellow. The fellows deserve the credit. They really do the lion's share of the work for this program. It's a divide and conquer exercise. We meet before DDW and you divide it up into groups. There's usually about 750 IBD abstracts this year. It's a little less since the meeting's just been virtual. We divide that up throughout the meeting. Each talk and poster is summarised, and the brief the fellows are given is to summarise each presentation they see in one PowerPoint slide. We then reconvene via Zoom, obviously, at the end of the meeting and decide, what we think is the most interesting and the most clinically relevant research from the year, which goes into the slide deck, which we're presenting tonight. Here's the Zoom meeting. It's a 4 or 5 hour Zoom to get through all of the content. It's a great group of people to work with. The faculty started in the US and now moved out through Asia Pacific and the UK, but it's really these guys that deserve the credit. It's the fellows. Particular call out to Madhar Chima and Alex Turbain were our Australian fellows who came from Liverpool and the Alfred respectively. The way that the program will be for tonight, being our second webinar, will cover 4 of the 7 topics: current and emerging therapies, including non-biologics and small molecules, disease activity monitoring and therapeutic drug monitoring, safety, adverse events and vaccines, and then finally our outcomes research, including some interesting pregnancy data, some post-op work and natural history work. There is a lot of data in this slide set. What we've done in the last couple of years is summarise what we feel are the top 3 take-home messages from DDW each year. So the first one was the CView study. This is our first good head-to-head study of biologic agents in Crohn's disease, which showed that both ustekinumab and adalimumab were equally and highly effective in achieving clinical remission at a year in Crohn's disease patients naive to biologics. Secondary endpoints of adverse events, which included infections and discontinuation, were numerically but not statistically higher in the adalimumab group. There was the second point. There was a focus on diet this year. In the first first webinar, you saw some data on the association between processed and ultra-processed food and the subsequent development of Crohn's disease. Here we'll present an interventional dietary study, the DINE-CD study, which compared the specific carbohydrate diet and the Mediterranean diet in Crohn's disease, a great initiative, although unfortunately this study endpoint was negative. There was no difference between those 2 diets. And then finally, and again presented last week, this emerging and growing entity of checkpoint inhibitor colitis, and we presented 2 studies that were multi-center observational data suggesting there are some aspects of vedolizumab use for this condition that are superior to infliximab: less hospitalization duration, less colitis recurrence, and even in one study, less oncological progression of the underlying disease. Move on now to the first section on small molecules. And just as a really brief background here, treatment options for moderate to severe IBD are very simplified schema of both induction and maintenance therapies for both Crohn's and ulcerative colitis combined. I just draw your attention to the bottom 2 rows. After we had 3 classes of biologics develop over really the last 10 to 15 years, it's interesting that our last 2 agents to reach the market, and this summarises therapies that are available, both registered and reimbursed in the US. But the last 2 agents have been small molecules, and they've been ulcerative colitis drugs. So the JAK inhibitor tofacitinib, this has been available in the US for 2 years. Very, very exciting news that it's available on the PBS for ulcerative colitis as of today. Ozanimod, the S1P receptor modulator, was approved for use actually during DDW. I think it was on the 27th of May this year, and we hope that that will translate to use here in the late this year or possibly early next year. So that's what our current pipeline is, and then there are emerging therapies as well. Susie presented data last week on the expanding class of anti-P19 IL-23 blockers. There are multiple JAK inhibitors in development for both Crohn's and ulcerative colitis. Filgotinib, which we'll see some data on tonight, and upadacitinib seem like they're the closest to reach the market. They're more selective JAK1 inhibitors. And then there are other S1P modulators, etrasimod as well. And we presented last week some interesting data on a different mechanism of blocking interleukin-6 via trans signaling, which doesn't block the membrane in ulcerative colitis. Moving on to some specifics now on S1P modulators. We're delighted to have the small molecule tofacitinib in our armamentarium as of today. It looks like ozanimod will be our next small molecule that will be available. An intriguing mechanism of action, S1P modulators trap types of activated lymphocytes in secondary lymphoid organs, including lymph nodes, therefore preventing their migration via the vasculature to the peripheral tissues, including the intestine. Multiple drugs, it's been in multiple sclerosis that have really led the way here. There's 4 drugs that are registered for use. Filgolimod is Gilenya, some of us will be familiar with, and then ozanimod, which is being most trialed in IBD. There are multiple other agents that are in trials for both MS and IBD as seen here. But the 2 IBD drugs that are at furthest in development are ozanimod, which blocks S1P1 and 5. The more selective blockade, the better, and the less toxicity, and in particular cardiotoxicity and bradycardias have been a risk with the less selective S1P modulators. So ozanimod, or the trade name is Zeposia, 1 milligram daily was FDA approved. It actually was in late May 2021, as mentioned. The drug development program for this is the True North studies. These were presented at DDW over the last couple of years. They were induction and maintenance studies. What we had this year were some post hoc analyses. The first one here is the question that was asked in this analysis is how quickly do these small molecules work? So we're looking at the True North data set, and here at the induction phase with the primary endpoint being at week 10, and we're looking at PROs, or patient reported outcomes, with the 2 most relevant for ulcerative colitis being the rectal bleeding score, which is the most sensitive, then stool frequency, and also biomarkers. So if we look at results in terms of speed of action on the left here, just one thing to comment is, as a means of improving safety and trying to overcome the risk of bradycardia, these drugs over the first week are dose titrated up. So for the first 4 days, you get 0.25 milligrams. For the next 3 days, you get 0.5 milligrams, and then you move up to the 1 milligram dose. That's done as a means of averting bradycardia. So if we look at the stool frequency score at the top left in the figure here, we can see a separation between placebo in grey, ozanimod in blue, starting around week 5. Even better for rectal bleeding score, with that separation indicating speed of onset as early as week 2, which is only 1 week after they've been at full dose. You can see here, if we look at the bar graphs now, over on the right, you can see for both of these PROs, there was a significant delta between drug and placebo for achieving those endpoints, or when they were combined, and also a reduction in calprotectin and CRP. So we conclude from here that induction therapy with ozanimod improves symptoms in patients with moderate to severe UC, including starting as early as week 2 for rectal bleeding score, with a parallel reduction seen in biochemical markers. So some encouraging data for speed of onset there for this class of therapy. Another post hoc analysis was the corticosteroid-free remission rates, which is obviously what was important. This is an analysis of maintenance data at week 52. The overall primary endpoint for the study, which was clinical remission at a year, was 37% ozanimod versus 19% placebo, a significant result. If we look at the patients that were on steroids, you can see that between a quarter and a third of patients were on steroids at screening, therefore stayed on that dose during induction and entered on into maintenance on that and were then tapered off. When we get out to week 52, again, looking at the left-hand side of the slide again, so there was endoscopic and histologic superiority over placebo. This drug development program was one of the first to include histology as a pre-specified endpoint in ulcerative colitis. And if we look at what the steroid-free remission rates at 52 weeks, we can see significantly better, 32% versus 17% ozanimod versus placebo. And patients that were either in response or remission at week 10 were more likely to maintain that through week 52. So a good and important post hoc analyses. These results were consistent across the sub-analyses as to whether they were anti-TNF naive or exposed, and also for disease extent, comparing left-sided versus extensive colitis. Systematic, combining biologics or combining a biologic and a small molecule. This is something that there's been case series emerging from some of the big centres in North America, from Calgary, from Mayo. For us, this is something that we can't access reimbursement for, but often if we work in conjunction with a rheumatologist or a dermatologist, we may be able to get these two therapies at once. Where this data set's gotten to is of a systematic review and meta-analysis. So there were 13 studies here. Interestingly, there was an RCT of natalizumab, which is not of relevance for us. The remaining 12 studies were just observational, just over 250 patients. The majority were treated for luminal IBD. There was about 30 patients where the indication was for extraintestinal manifestations. The logic here is to combine a gut selective agent with a systemic agent where possible, or certainly use two very different mechanisms of action. You'll see if you look at the numbers in the studies, going from top to bottom, the largest numbers are using vedolizumab for its gut selectivity. And if we look at the clinical and endoscopic remission rates, remembering that this is a tough population, by the time you get to a combination biologic, you've failed multiple therapies or you've failed either therapy when used on its own. So pretty acceptable clinical remission rates of sort of 40 to 50%, endoscopic remission rates of 25 to 30%. The issue here is side effects. You're combining two often immunosuppressive drugs, or at least one, and infections are the risk. That's been demonstrated in all the series, but it hasn't been disproportionately high. And when these data were meta-analysed, there was no new signals, new safety signals that emerged. There'll be a small patient subgroup for which combining therapies, I think it's a better term rather than combination, combining therapies would be appropriate if we're able to obtain them. Let's look at some tofacitinib data now. This drug is available for use as of today. Where the data set's gotten to here is looking at real-world observational studies. We've obviously seen the Octave clinical trial program over the last couple of years and the analyses from that, and also some systematic reviews of both real-world studies and RCTs. So the first two studies, the first two rows here, are most interesting. The first study was retrospective. This was from University of Chicago, just under 100 patients. So we're talking about ulcerative colitis patients here, almost all of whom had failed an anti-TNF. A really nice endoscopic remission rate. What was unique about this study was this is the first tofacitinib data on histological response and remission, which occurred in a third of patients at a big referral centre of Chicago, so a good result. The next study down line 2 is even better. This is from Leuven, it's prospective. What was interesting here, and as you can imagine, as the program for this molecule's developed, all of their patients essentially had failed an anti-TNF, but 93% had failed vedolizumab as well. Their clinical and these were a sick cohort, their clinical and endoscopic remission rates were lower, but still acceptable, and pretty good histologic remission as well. And you can see, just for interest, there are now systematic reviews of both the observational and RCT that are consistent with the clinical trial results. But what's novel here is data in patients failing 2 biologics and some histological improvement data. Moving on to another JAK inhibitor now, so filgotinib. Filgotinib is a selective JAK1 inhibitor. Tofacitinib is non-selective. It predominantly blocks JAK1 and JAK3. JAK2 is the one you want to avoid. That's the one where there's significant hematological side effects. So the filgotinib JAK1, this is Gilead's molecule. The program here, the selection studies of the ulcerative colitis program, the diversity studies of the Crohn's program, they presented here both the induction and maintenance studies combined. This was a program where it was a phase 2b/3 studies. There were some dose ranging studies initially in the program. What we're showing here is the combination of all of the induction and maintenance results. So for induction, these are ulcerative colitis data. The primary endpoint was at week 10. There were 2 doses, 200 milligrams and 100 milligrams compared to placebo. There were 2 identical studies, study A, biologic naive, study B, biologic experienced. The primary endpoint was clinical remission at week 10, and then the maintenance endpoint was at week 58 by the usual criteria that are now shown here that are used in an ulcerative colitis study. Over 80% of the patients had had anti-TNFs. Half of them had had FeNO, and 40% had had both. Then we move on to maintenance, and for between week 10 and week 58, 200 and 100 compared to placebo. As is normal in such a program, responders to placebo induction continued on that. Looking at the results now over onto the right of this slide, really nice sample size, almost 700 patients in each induction study and over 600 in maintenance. The take-home message here is that for induction therapy, it was the 200 milligram dose that was significantly superior to placebo. The 100 milligram dose wasn't. The biologic naive had a greater response than experience, as would be expected. Whereas where it comes to maintenance, both the 100 and the 200 milligram doses were significantly superior to placebo in maintaining remission. Overall adverse events were relatively low and not different for placebo. There are some signals with JAK inhibitors of zoster. These results were infrequent with this more selective blockade. There's also a concern about thromboembolism with this class of therapy. There was 1 pulmonary embolus in the 200 milligram induction group. Overall, these are encouraging results for this molecule. There has been an animal model of some spermatogenesis changes with this drug that still needs to be overcome by, and there is an ongoing MANTA study that is going to hopefully give us some reassuring results there. Now, a dietary intervention study. This is from Jim Lewis and his group at University of Pennsylvania, DINE-CD. It's great to see the US getting involved in some dietary research, and Jim's really leading the way. So a couple of things, and the study design here was, had some things that I think ended up contributing to the overall lack of difference between the 2 study groups. So first, this was just mild to moderate patients with Crohn's disease. This is a Crohn's disease study. They used what's called a short CDAI, which has just got 3 components: abdominal pain, diarrhea, general well-being. It has the same cutoff of less than 150 for remission. Inclusion was based only on symptoms. It was not based on objective activity of disease. If you look at the table at the bottom bottom left, objective inflammation in the 2 groups, it's about half of patients for each of these diets had objective inflammation. Before we go into too much detail, we should just discuss the diet. So the specific carbohydrate diet has a high intake of unprocessed meats, poultry, fish, eggs, most vegetables, fruits and nuts, restricted certain carbohydrates, grains and dairy and sweeteners other than honey. The Mediterranean diet, in contrast, has lots of olive oil, fruit, vegetables, nuts and cereals, but minimises red and processed meats and sweets. And there has been multiple studies before, showing some symptomatic efficacy of these diets, mixed results, but they've never been compared. What was done in this study, so this is an induction study of patients with active Crohn's disease. The primary endpoint was at week 6. For the first 6 weeks of the trial, Patients were provided with the food for each diet. It was a randomized, a 1-to-1 study. For the next 6 weeks, from week 7 to 12, they obtained their own food. Reasonably nice study size, 190 patients equally matched between groups. So when you put patients on this specific diet, there was an improvement in their CDAI, short CDAI, and quality of life, as measured by IBD from baseline. But in terms of the primary endpoint at week 6, there was no difference between the groups, 44% for the Mediterranean diet and 47% for specific carbohydrate diet achieving remission. Importantly here, neither diet was associated with normalization of CRP or calprotectin, which were pre-specified endpoints. And again, there was no difference in patients with or without inflammation at entry. These are week 6 data. If we go over to the right here at week 12, we can see, nice symptomatic remission by short CDAI, clinical remission by CDAI, but significantly less objective evidence of improvement of inflammation. So, some flaws perhaps in the trial design, but interesting that when patients are given a diet and follow this, that they a significant component feel that their symptoms improve. That's the end of this first section. How are we going, Susie, for questions here?
So Jake is on the line tonight and he's made a couple of comments. The first one is around ozanimod. Given the mechanism of action, we think of ozanimod blocking egress of immune cells from the lymphoid tissue. How can the response be so rapid? I wonder which immune cell populations are being affected to drive this rapid response. So it's kind of more a comment. Did you want to address that, Miles? Or?
Yeah, Jake, typically a great comment, and I don't have a good answer. It's symptom responses early. What I'd like to see is objectively whether they're improving as early with their biomarkers. But yeah, the other drugs that we know that act on lymphocytes, azathioprine, vedolizumab, etc., where primary mechanism of actions on lymphocytes do act slowly. So why is this different? Good point, Jake. Sorry, I can't come up with a better answer.
Yeah, I mean, he's about, he. Now, Jake's also made another comment. There was some hope that JAK1 inhibitors might be equally effective in anti-TNF failure patients as bio-naive. But that does not seem to be the case, although the deltas seem similar. What was your impression?
Yeah, again, Jake, this is one of the things that largely the tofacitinib data set does show that the drugs work equally effectively in anti-TNF naive or experienced. Yeah, that wasn't shown here. I must admit, I don't know what in the other JAK1s, upadacitinib and etc., what the difference is. But as you point out, the delta is the same. So I think the numerically, obviously, it was less, but the delta, which is really what's important, isn't it, was the same. I think we probably just need to see a bit more data and with some other molecules before really knowing whether these agents work as well in experienced patients. Okay, this is some work from University of Pennsylvania, leaning heavily on work done in Pittsburgh and by David Binion previously. The question they asked for this study is there anything that we're seeing in the routine results that we all order day to day in clinical practice that we can use to prognosticate our patients and show patients with more aggressive disease? And they looked at 4 factors here that are common tests that we all order. They looked at eosinophils on histopathology, granulomas on histopathology, eosinophils in blood, and monocytes in blood. This was a retrospective cohort of their patients on infliximab, almost 300 patients. There was 2 components to this study. First, they created a weighted composite scoring system using these 4 variables based on the outcome of infliximab discontinuation, which was their outcome variable of interest. So an example of this, if we look at over on the right here, let's look at the first row, granulomas on pathology. If these were looking at that, if these were absent patients from this model lasted 7 years on infliximab. If they were present, they only lasted 5.5 years from their database. And so therefore they came up with this weighted score of what that component was, which all totals down to 1. Then they went back and they used their model scores and they correlated this with healthcare utilisation and clinical parameters. And higher composite model scores were associated with worse outcomes, higher healthcare utilisation, more clinic visits, more scopes, more steroid use, worse biomarkers, and a significantly higher likelihood of stopping infliximab. I think this is really nice, and I think certainly with granulomas and probably with eosinophils, there is something there that we should be looking at. We do some of the more expensive and newer technologies of measuring drug levels, measuring serology, doing a lot of obviously endoscopy and imaging. Maybe there are some simple things that we can look for in inexpensive tests that can allow us to prognosticate a bit. Obviously this needs to be replicated elsewhere, but this is the second centre that's now shown the association between these factors and worse outcomes. I think it's really nice data for us to have a look at ourselves. We've combined here 3 studies on this concept of visceral adipose tissue, or VAT, and worse potential for worse outcomes in IBD. The background here that the speakers gave, and there was Philip Gu from Texas did the first retrospective study, and Andres Urua from Wisconsin, the prospective one, which is the better study. They all started by saying that in the past, when we've looked at adiposity and tried to quantify it by BMI, that's inaccurate. And they showed these very convincing images rather, of patients who had a normal BMI, but significant visceral adiposity on imaging, be it dexitometry, ideally with no radiation, or CT. So the first one was from Texas, and this was a retrospective study. And they looked at patients starting anti-TNF and compared visceral adiposity as measured by CT, and they looked at visceral adipose tissue and what's called they called a visceral fat index, which is the ratio of visceral to subcutaneous fat. And the outcomes they looked at was response to anti-TNFs and risks of surgery. There was about 180 patients in each of those overlapping cohorts for those outcomes. The first thing in the figure at the top right, you can see with anti-TNF response at 12 months was less in this highest tertile of greater than 3,000 cubic centimetres of VAT. It wasn't a linear response, it was just this highest tertile. And they also, when they looked at their index and they defined a cutoff of 0.67, patients with more visceral fat by this index had a higher risk of surgery at 6 and 12 months. These are retrospective data. They combined Crohn's disease and ulcerative colitis, and they only looked at anti-TNFs. The better study at the bottom was Constellation, which Andres is driving from Wisconsin. This was prospective. This was an induction study. Its patients started on any of infliximab, vedolizumab, or ustekinumab, and they looked at the association between baseline VAT percentage and response at week 14, 125 patients. And you can see here, if we look at the figure at the bottom right, that the higher quartiles of visceral adipose tissue percentage had less rates of deep steroid-free remission at week 14 in blue, week 30 in green, and less endoscopic remission in the pink there. They didn't differentiate between underlying diagnoses. They didn't differentiate between drugs. But, I think there is a signal here. I think we need to be really proactive in weight loss and, perhaps acknowledging that our more obese patients via a number of different sort of pharmacokinetic and inflammatory mechanisms may end up needing higher doses of drugs and biologics in particular. Really nice data, I thought, this year. And then finishing, last 2 slides for me are on COVID. This is looking at another analysis from Secure IBD. Secure is the global registry of COVID that's set up by a number of entities. A lot of the analyses are driven out of Mount Sinai and Ryan Ungaro in New York. This is a referral centre database. They've got really nice numbers. It's largely offered us some reassurance that our patients, even those on biologics and immunosuppressants, are doing reasonably well. The analysis that looked at here was what is the effect of the underlying IBD disease activity and age on COVID outcomes. They defined disease activity just by physician global assessment as mild, moderate, or severe, and the severe COVID outcomes were either hospitalisation or a composite of ICU, ventilation, and death. We're out to 3,000 patients for this analysis. Thankfully, only 5% ended up in ICU, 20% hospitalised. So what they did show is that increased IBD activity was associated with worse outcomes with COVID, but it was only independently associated in patients less than 50, i.e. our younger patients. If you look at the table at the bottom here, you can see that for the top half in red is in the younger patients less than 50. It was the patients with severe disease activity here who had worse outcomes for both ICU, ventilation, death on the left, and hospitalizations on the right with clear confidence intervals. And if we look at the bottom in the older patients, confidence intervals are crossing 1 for all degrees of disease activity. You can see here shown graphically, there was a linear increase in severity of outcomes with disease activity. The message for us is young patients with severe IBD should be prioritised for COVID vaccination. And then finishing now with some population-based data, again, a familiar message of steroids are the bad guy, but we included this because secure IBD is a very much a referral centre-driven database. These are population-based data presented by Fernando Vallejos from UCSF. This is using Kaiser Permanente's data. It's almost 40,000 patients with COVID. It was not only IBD, it was all immune-mediated inflammatory diseases. The primary outcome, again, was severe IBD, defined as risk of hospitalisation, ICU, or death. And the question they were asking is, what is the difference with the severity of outcomes and the underlying outpatient medications as determined by pharmacy prescription refill? And you can see here, if we look at the results in the table, again, it's corticosteroids are associated with worse outcomes. Obviously, in an observational study like this, they can't control for disease activity. Were these sicker patients? Of course, they could well have been. But reassuringly, as per the secure data set, no signal with immunomodulators or biologics or other small molecules, and worse outcomes, and no increased risk of IBD versus other immune-mediated inflammatory diseases. So, some population-based data with a similar message about, the need to minimise corticosteroid exposure in our IBD patients, including those with COVID. So that's the end of my slides. How are we going, Susie, with questions?
There's no questions, but I had a question for you. I just wanted, with the VAT and the visceral adiposity data, do they look at drug levels at all? Biologically,
no, they
in
didn't.
terms of they'd look at if that was independent. They didn't.
They didn't. It came up in questions, and they acknowledged that was a limitation, but no, they didn't.
Right, okay. And also in the first study, the retrospective one, did they differentiate between adalimumab and infliximab, or just group them all together?
Group them all together. Again, another limitation. I think from memory, Susie, that the majority of patients were infliximab, but no, they were all analysed together.
Okay, all right. Great. So I'll just take over now. This is a slide. This study is from the group in Exeter, led by Nick Kennedy and Tariq Ahmed, looking at the use of a finger prick test. So this study was called the PRICS test, which I love the title. And essentially looking at patients, because of COVID, they had to think about remote monitoring. Patients essentially were sent a kit in the mail, did a finger prick test, and then sent the results back to the lab, and they compared that with normal conventional venipuncture. And they also looked at acceptability for patients. There were 103 patients, and how they defined, whether the intracapillary testing for therapeutic drug monitoring was equivalent to venipuncture was by looking at linear regression, and also this, what they called fit for purpose equivalence, was by a total allowable error, which is essentially having the values within 95% confidence interval of the serum levels. And essentially, you'll see in the results here on the left, essentially the drug level equivalents and the anti-drug antibody equivalents were good. I think the message is better portrayed on the right. And if you see down the bottom, there's a linear regression graph, and essentially the little blue dots are the observations, and then you've got the red lines are the 95% confidence intervals, and what they define as a total allowable error. And you can see that the vast majority, and then look, comparing venous adalimumab to venous TDM to capillary TDM, and there you can see that the vast majority of observations are within the predefined total allowable error margin, and the Bland-Altman plot above, essentially looking at the mean of the venous and capillary levels, and the difference between the two essentially is just another way of portraying the same thing. And essentially the figures on the left tell us basically the same story, and they didn't actually tell us specifically how numbers of each of these groups, but it was equivalent across all the different drugs: adalimumab, infliximab, vedolizumab, and ustekinumab. And as well, they designed, as I said, a survey, and patients liked, found it acceptable, and in fact preferred it to standard venipuncture. So it'll be interesting. I think they're interested in doing further study on this as an option for remote monitoring for patients. This is a study, well, it's not a study, it's actually an international consensus conference. And the reason we brought this up is because of the issue around histology and trying to get some consensus around what histology to use, and particularly in the context of Crohn's disease. So essentially what this group did was it just happened before COVID, a whole group of expert pathologists, gastroenterologists and researchers from across the Northern Hemisphere met in Erlangen in Germany to try and sort out 10 statements for harmonising biopsy both procedures in IBD, and then actually developing a concept for a new index histological activity for both UC and Crohn's disease. And they used a 2-round modified Delphi panel, and then proposed this new score, and then looked at reliability across pathologists and also with the current UC histological indices. On the right, you'll see the actual score itself, and what it's called is the IBD DCA, which stands for distribution, chronic features and activity. The distribution basically is done by looking at a scanning magnification assessing overall the percentage of tissue affected. So either normal at 0, and each time it's just a 0, 1 and 2. Then looking at less than 50% of the tissue affected, or greater than 50% of the tissue affected by inflammation. And then there's the chronic features, which is looking specifically at crypt distortion or lymphoplasmacytosis, and it's discriminated between normal and then mild or marked. And obviously there would be some, subjectivity around what's mild and marked. And then activity, which was based on activity based on acute activity, which is around neutrophils or crypt abscesses, and that again is defined as 0, 1 and 2. And then the patient basically the histology gets a score of between 0 and 2 on all 3 features. If D is 0, then obviously by default C and A will also be 0. So what they found was good inter-rater reliability among pathologists for ulcerative colitis and moderate for Crohn's disease. Intra-rater agreement was good to excellent in both cohorts, and there was moderate correlation with the Nance histological index and strong correlation with the Gerbe score. So I like this. I think it's intentionally simple so that there's high acceptance among pathologists and clinicians. So I'm really interested to see how this progresses and in terms of use in clinical practice and what happens next in terms of, I guess, validation of this score. And I think one of the other really good things about it is that it's simple, And also you can actually also differentiate between histological remission and actual true normalisation. So I'm hoping this will become something that we use in standard practice, because I mean it is also very simple. Now this is looking at out of class switch after anti-TNF therapy, but actually out of class switch, across biologic agents, but the majority were anti-TNF patients. So what this was looking at it was retrospective case control analysis of 17,000 samples from the Prometheus lab. And what they looked at was the cases were anti-drug antibody positive patients, and the controls were anti-drug antibody negative. And essentially they looked at then switching from one anti-TNF to another anti-TNF, and what the percentage of anti-drug antibodies were with the second anti-TNF, and that was 50% of the cohort. And then there was about 43% were had switched from anti-TNF to out of class switch, and then the rest of the percentage, which is 6%, was between either going from ustekinumab to vedolizumab to anti-TNF, or to between the two. So essentially what they found was that in terms of, first, if you look on the left of this of the figure on the right of the screen, that if you and the blue are people that are anti-drug antibody negative, and the red are patients that are anti-drug antibody positive, and essentially the chances of developing immunogenicity with the second anti-TNF agent are significantly higher if you're already positive for the first anti-TNF agent, and that held if you switch from infliximab to adalimumab, was particularly the case if you switched from adalimumab to infliximab. And you can see the differences here between those who are anti-drug antibody negative and anti-drug antibody positive, and the numbers are largest in the anti-TNF to anti-TNF switch groups. And then looking at the switch between anti-TNF and vedolizumab, you'll see immunogenicity was less, and in fact only 3.7% of patients developed anti-drug antibodies to vedolizumab if they were positive for an anti-TNF, and 2.3% with anti-drug antibody who were anti-drug antibody negative. But there was still a difference between the two, although the delta is just over 1%, so pretty small. And then the numbers for ustekinumab, immunogenicity even less between across the board, but there was still significantly an increase of anti-drug antibodies between those who were previously positive for anti-TNF. But as you can see, the immunogenicity is very low in these two drugs. We switched these two drugs, which we do know. The other comments to make was that the development of anti-drug antibodies was highest in the first year, and obviously, as is pointed out as well, that was switching between anti-TNFs compared to other classes, and so particularly important then to watch patients closely in the first year. Anti-drug antibodies did develop subsequent to the first year. It was much, much higher in the first year, so that's when you need to keep a close eye on patients. This mirrors the prospective study which was published in Gut last year by Xavier Roblan, looking at switch between one anti-TNF to another when you were previously positive, anti-drug antibody positive. So this sort of basically confirms that prospective trial. One of the limitations of this study, apart from the retrospective nature, that it was only looking at samples, drug sample, as in blood serum samples, so there wasn't any clinical or immunomodulated data associated with these results. The final study for this section is an Australian study which involves a number of people, I'm sure, on the call. It's led by John Ding and Miles, and it's an ANZ IBD consortium study called Fiscal. 10 centres, a cross-sectional retrospective study looking at the at radiological healing in perianal fistulizing Crohn's disease and the association with anti-TNF drug concentrations. Now, it was pelvic MRI was the radiology used, and the activity was scored using the Van Asch the subscore of the Van Asch index, which was derived from the indices of hyperintensity on tissue-weighted imaging, collections of greater than 3 millimetres, and rectal wall involvement. And these are each given a score of 0, 4, or 8. Depending, for example, of hyperintensity, I think it's 0, 4, and 8, and then collections of yes or no, it's 0 and 4, and then rectal wall involvement is 0 and 4. And essentially, the score basically is there might be two actually for someone I've forgotten, sorry, but essentially radiological active disease is a class as an inflammatory score of greater than 6. Healing was less than or equal to 6, and remission was a score of 0. Patients had to have had a drug level done within 6 months of the MRI being done. The vast majority had an MRI within 3 months of the level being done. There were 193 patients, more patients on infliximab. If you look over here on the box and whisker plot on the right, you can see the correlation with across tertiles, the association with drug levels and activity of radiological disease activity. The left is infliximab levels and the right is adalimumab levels. And as you can see, the drug levels are higher going from active disease radiologically up to remission on the right. And this held for both drugs and was significant. We did, the group also did look at optimal trough infliximab levels for radiological healing and remission, and and found levels of 4 and 6 respectively for infliximab and for adalimumab, 7.2 and 9.7. The ROC curves were only about sort of 0.65 to 0.67, but certainly you can see those numbers as they are. I just want to, Michael Di Gregorio is essentially is the PhD student involved in this, and this work has then informed the proactive study, which we're going to do prospectively, looking at radiological and clinical healing and drug levels. So that's the end of this part of the first part. And Miles, I don't know if you want to make any other comments, given that you're one of the leads on the physical study, and are there any other questions?
Look, yeah, just Susie, there's some great questions coming through, so I'll be brief with comments. Just really quickly, you know, the drug level cutoffs on the ROC curves that we got were significantly lower than other studies. I think it probably just reflects the prescribing restrictions we have in the PBS, and it's harder to get a drug when you need it in this tough phenotype. But the signal is exactly the same. And as you said, you know, Michael Di Gregorio really deserves the credit for this work, Susie. There's some great questions. So the dynamic duo from Brisbane, Susie, Jake and you. A practical question first from Jake. In the fingerprint TDM study, were the bloods collected at home sent into the centre to do the TDM, or was the TDM test done itself by the patient? Such as by
No. So what happened was the patient did their fingerprint test at home and then posted the blood back to the hospital in the mail at room temperature.
Okay, great. And Yoon has asked, in terms of the histologic index presented, do you think this is ready to go for future research, either industry or investigator initiated? Do you think this histological index will be uptaken? And there's a second question, Susie, on that, that's from Thomas Lee from Wollongong, and Thomas said it's interesting that granulomas were shown earlier to be worst outcomes, but they're not included in the index in Crohn's. So question from Thomas there.
Yeah, I think that is interesting, isn't it? Yeah, that's a good comment, Thomas. I do, yeah, it is interesting. I don't know why they reached that consensus not using granulomas as part of the Crohn's disease activity index. I think they were just trying to look at chronicity, specifically around chronicity and activity and distribution, rather than specifically about granulomas. So just trying to work out, is this patient in normal histology, or do they still have active disease, or do they have chronic changes only? I think that's the point of it. Whether it's going to be mainstream or not, Yoon, I really don't know at this stage. I guess we'll wait and see. I don't know the answer to that at this stage, no.
And then, look, there's a final question from Jake. And Susie, maybe both of us should answer this.
Yes.
So Jake said, you know, what's your current practice with anti-TNFs and fistula? How high do you go? Look, Jake, me first, I'm pretty simpleton with this stuff, and the more the better. And I, do aim for an infliximab level of around 10 if you can. I'm a bit less certain what it is with adalimumab, but probably same ballpark or more. Susie, what do you think what were the targets in proactive that you guys have designed?
It's going to be over 10 in maintenance. and then during 25 and 15 at week 2 and week 6 during induction.
Okay.
That's for infliximab, and then maintenance is 10, and that's based on Niels van der Kastel's current advice.
Okay.
Yeah.
All right. I think that's it for questions, Susie. Maybe we'll move on.
Okay. Thanks. That's great. So this is looking at, it's only a small retrospective study from Cedars-Sinai trying to sort out post-operative morbidity with ustekinumab. And what they had, they defined patients, the ustekinumab level was collected on the day of abdominal surgery using the Prometheus assay, and essentially patients were divided into undetectable ustekinumab levels or detectable ustekinumab levels, and then looked at 30-day post-operative outcomes. There were 36 patients. The majority had Crohn's disease. 2/3 had detectable levels, as I said, greater than 0.9 micrograms per mil, and 31% were undetectable. In fact, the median concentration in the detectable group was 6.4, and up to 25, in fact, in the those that were detectable. The baseline characteristics were similar across both groups, except that in the detectable groups, they did have a higher, significantly higher hematocrit and albumin compared to the non-detectable groups. The summary of the findings is on the right, and essentially there was no difference between those patients, albeit with the small numbers, between the undetectable and detectable group in terms of overall morbidity, ileus, wound infection, leaks, ICU stay, or 30-day readmission, or post-operative hospital stay. So I guess it's I don't know if there's a prospective study going on, but at the moment this is all we have, and I guess the data is reassuring. I guess given the anti-TNF data doesn't show increase in post-operative morbidity, one would hope that ustekinumab wouldn't either, given its safety regime. But essentially, anyway, that is safety profile, I should say. Anyway, this is the results we have to date. This is looking at the tofacitinib safety data in ulcerative colitis, and it's Pfizer post-marketing voluntary case reports, and it's comparing the safety reports from the ulcerative colitis from for the first 27 months from 2018 to 2020, and comparing that to the 36-month safety data for rheumatoid arthritis from 2012 to 2015. Just under 9,000 patient years for ulcerative colitis and 34,000 for rheumatoid arthritis. And the adverse events is over on the right, as you can see in the table. Just a couple of comments. Ulcerative colitis patients were more likely to be male, and they were also younger compared to rheumatoid arthritis patients. Essentially, the safety data appears to be similar between rheumatoid arthritis and ulcerative colitis. In terms of the gastrointestinal events, they were more common with ulcerative colitis compared to rheumatoid arthritis, which you'd expect given the disease state. Infections and this is looking at the rate is per 100 patient years, and every group was equivalent. The infections were, the majority were C. diff, pneumonia, COVID, CMV, and herpes zoster. Malignancies, the risk were similar between the two groups. Serious cardiovascular events were also similar between the groups. The vascular events, unfortunately, they included non-gastrointestinal hemorrhage, thrombosis, and DVTs. But pulmonary embolism, unfortunately, was not included in this group, and was actually included in the respiratory events, which I think came under the infections and infestations, but wasn't actually classed as a separate entity, unfortunately, or grouped within the vascular events. So we can't. I am unable to comment on that. Death rates were similar between the two disease states, and so. At the moment, this is based on the data up to now. The other weakness, of course, of this is that it's voluntary case safety reports, which obviously is a weakness, but these are the results as of now. The next one is looking, and this is actually being published in Gastroenterology Online in March and July in paper form. It's essentially looking at the issue of paternal exposure to immunosuppressives and birth outcomes, specifically preterm births, low birth weight, and congenital malformations. This is from a claims database. It's called the Optum Data Warehouse. The data was collected between 2005 and 2018 and looked at inflammatory bowel diseases, rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. They collected men who were between 20 and 55 years of age, had been exposed to immunosuppressive therapy between 34 and 60 weeks prior to delivery. And this is based on sperm turnover being up to 90 days and the average time of delivery between 38 and 39 weeks of pregnancy. And the maternal linking was performed to remove maternal factors. There were 1,846 exposed fathers. And unfortunately, one of the weaknesses was they weren't able to assess infertility, abortion, or stillbirth. They're only able to look at these major congenital malformations, preterm birth, and low birth weight. So essentially, comparing the groups, essentially there was no difference in terms of the exposed and the unexposed fathers and babies that were born in terms of congenital malformations. This is the bottom table. Preterm birth and low birth weight. I just want to show you above the vast majority of dads had been on anti-TNF and thiopurines. About 171 had been on methotrexate, just under 10%, and non-anti-TNF agent was about 7%. So I guess, the data is reassuring. We did have some discussion about what it tells us about methotrexate. The Danish, I reread the paper today to look at it again. I mean, the issue really is around sperm fragility and motility in methotrexate. The Danish prospective COA data has been reassuring. The numbers, though, are small for methotrexate. I think, it's certainly reassuring in terms of thiopurines and anti-TNF. Whether there's any longer-term outcomes in terms of baby, we don't know, obviously, from this data. And, of course, it'd be lovely for us to get some prospective outcomes, prospective studies, but whether that happens or not, I think the consensus from the editorial is unlikely that that'll happen. So this is the largest retrospective work results we actually have at this point in terms of paternal exposure. Oh, that's actually the end of this this group of slides, Miles. How many questions do we have?
Yeah, we haven't got any questions from that section, Susie. Maybe just following on from the discussion from last night, it came up in the chat that rheumatologists don't routinely suggest to males to start a family that they stop methotrexate. Many gastros do. It's a pity, Susie, isn't it, in that study? I mean, as you pointed out, the issue's sperm fragility with methotrexate. It's not teratogenicity, and they couldn't assess for that via, indirectly via infertility in this analysis. So it's like any observational data, there are confounders, but it's
I guess David Prince made a very sensible comment to me, because we were looking at the paper again today, and he said, that go back to our basic embryology, thousands of sperm go for that egg, only one hits it, so it's likely not to be the fragile or poorly functioning sperm that get there, if in terms of getting there. But the issue, as you said, whether it affects fertility prior to that is an issue which wasn't able to be assessed in this study. And I think it's still going to come down to discussions with patients and their husbands or partners or, mums and dads when they are, deciding on conception. And obviously individualised discussions will happen, and based on people's risk and, concerns, etc. I am going to talk about it at our rheumatology meeting in a couple of weeks' time, but anyway, so I'll feedback. So this is looking at more work from the piano study. This is looking specifically at, the piano cohort. This is looking at the corticosteroid use in pregnancy. And it's, we all know the piano registry. patients and their mums and babies, looking at mums and babies at each trimester. Questionnaires are filled out and at delivery, and then forward 9 and 12 months postpartum, and looking at pregnancy outcomes, in this case comparing pregnancy outcomes by corticosteroid exposure during each trimester of pregnancy, and then looking at the outcomes. Now, the findings basically you can see on the right with the table, the sort of key findings are that there is corticosteroid exposure during pregnancy was associated with an increased risk of low birth weight, preterm birth and NICU stay. Now, the issue with this is that they did say that they corrected for disease activity, and that mums who didn't have disease activity but did have corticosteroid exposure still had these worse outcomes. The problem with that is that why would somebody who doesn't have any disease activity be actually exposed to corticosteroids? So there was that sort of caveat around, whether they did or didn't really correct for disease activity. But anyway, the data that was presented is what it is here, that if you had been exposed, there were these outcomes that were worse, and whether how good the correction of disease activity was or not is a bit unclear. The other thing that came out from this study was that first trimester exposure to corticosteroids did have an increased risk of congenital malformations, which was 9% compared to 11%, and that was in the when there was in the first trimester exposure to steroids. There were 5 cleft palates in the exposed and 1 in the non-exposed group, but wasn't able to be able to make any sort of statistical conclusions from that due to the small numbers. I think the take home really from this is that I think we need again to have the importance of preconception counselling and try to have our mums in remission prior to pregnancy, so that we can avoid using steroids during pregnancy, and obviously continue to use our steroid-sparing agents to keep patients and mums in remission prior to becoming pregnant. This is a 2-centre retrospective study looking at the effectiveness of anti-NF agents, ustekinumab and vedolizumab, on post-operative Crohn's disease recurrence. This was propensity score matched, and what they did was they basically propensity match scored all the based on other disease characteristics, and looked at no post-operative biologics compared to anti-TNF, ustekinumab and vedolizumab. There were 991 patients involved in this study between 2009 and 2019, and it was ileoclonic resections. Recurrence was defined as endoscopically by Root-Gert score of greater than 2, or by radiologically active disease based on active inflammation in the terminal ileum. And essentially, you can see on the right and the Kaplan-Meier curve looking at recurrence-free survival, and the none is in the green, and then the anti-TNF in sort of orange, ustekinumab in blue, and purple vedolizumab. And essentially, there was no difference between the 3 drugs in terms of agents. There were the vast majority of patients had anti-TNF, 432. Ustekinumab was only 52, and vedolizumab was 72. But they were propensity matched, as I said, but there appears to be no difference in terms of post-operative recurrence in terms of the 3 drugs. Numbers are relatively small, and the ustekinumab group did appear to be potentially significant, but I don't think we can say that because the numbers aren't big enough to really say that there was any significant difference with ustekinumab over the other 2. This is from the Cleveland Clinic, which is sort of the home of post-operative recurrence, in addition to obviously Michael Cameron Peter de Cruz in Australia. And this is a retrospective cohort looking at patients who underwent ileoclonic resection between 2009 and 2020, 877 Crohn's disease patients who had an ileoclonic resection. Now, trying to tease out the role of imaging. So patients had to have a colonoscopy and imaging, CT or MRI, within 90 days of endoscopy. Postoperative recurrence was defined as a root GERDS of greater than or equal to I2. I'll go through the findings a bit more on the right in a minute. Essentially, cross-sectional imaging. So first we're looking at if the patient's had postoperative recurrence what they've looked at is E positive is endoscopic recurrence, E negative is no endoscopic recurrence, R negative is normal radiology, and R positive is positive radiology. So the first thing to say is in terms of whether there's known endoscopic postoperative recurrence, cross-sectional imaging was sensitive at detecting postoperative recurrence at 89%, but very poorly specific. In fact, at 31%. So I've mistyped that. It should be 31%. You can see it over here on the right, on the graph on the right. My apologies. In terms of the features of increased disease severity correlated well with endoscopic severity. So if you look here on the right, I'm just going to show you the endoscopic severity was things like length of disease, segment, hyperenhancement, and luminal narrowing. They correlated with more severe postoperative recurrence. And I'll talk to you now about the discrepant groups. But before I do that, I'm just going to show you here on the right the different, this is endoscopic, you see the bottom graph here, endoscopic postoperative recurrence, which is 76, and no postoperative recurrence in 125. And looking at the radiological features, so if you had postoperative recurrence, you were more likely to have radiological features of intestinal wall thickening, hyperenhancement, and luminal narrowing. Compared to those patients who didn't have postoperative recurrence, but you can still see there were patients that did have those features without postoperative recurrence on their endoscopy, I guess highlighting then the lack of specificity. However, I guess the question you're asking, and I certainly was asking this, was if you had no endoscopic recurrence, but then actually had radiological recurrence, what does that actually mean for patients? And essentially, there was a doubling in the rate of those patients going on to have endoscopic and surgical postoperative recurrence compared to those that were in remission, both negative in both radiologically and endoscopically. But there was no difference in time to endoscopic recurrence or surgical recurrence. So I think the take-home from that is essentially the take-home from this paper is, first of all, endoscopy remains the gold standard in terms of assessing for postoperative recurrence. And then obviously then using postoperative recurrence assessment is endoscopy first, and then that will tell you whether the patient's going to get clinical or recurrence down the track as root GERDS defined years ago. However, I guess the other point is that that in patients where you can't do endoscopy, or you happen to have radiology, it can be an adjunct. And then obviously in patients where you aren't able to do endoscopy, you could then use radiology as an adjunctive imaging in the context of not being able to do endoscopy. So I think it can be an adjunct. I don't think it replaces endoscopy in terms of looking at postoperative recurrence, but it can be an adjunctive test in certain circumstances. This is the Explorers database, which is another one of these big claims databases, which Cleveland Clinic has access to, and this is looking at the issue of osteoporosis and bone fractures, and it's a national population-based study. They looked at patients. There were 31 million patients in the database, of which 135,000 have Crohn's disease and ulcerative colitis, 112,000. And they compared patients who received biologic therapy versus those that don't. If you look at the graph on the right, the blue is biologics and the no biologics is in orange. As you can see, and the osteoporosis is on the left, bone fractures are on the right. And you can see that there is an increased risk of both osteoporosis and bone fractures in both Crohn's disease and ulcerative colitis. And it's with people that have had biologics versus no biologics. And the difference occurs across both disease states, but it appears the delta seems to be a bit bigger in Crohn's disease for both, but does hold for both disease states. So in other words, the biologics appear to be protective for osteoporosis and bone fractures. The question then is about what about steroid use? And in fact, 94% of patients with Crohn's and 93% of patients with UC had corticosteroid exposure, but the cumulative amount of corticosteroid exposure was not able to be was not part of the. We weren't able, that wasn't told to us what the difference is in terms of cumulative, just that the vast majority of biologic patients had corticosteroids at some point. So essentially, there is something about biologics. Now, we know that inflammation does increase your risk of osteoporosis, and that in itself is part of what's driving osteoporosis and IBD. Whether there's something else apart from control of disease, that is the reason why biologics are protective for osteoporosis or not remains to be seen. But certainly there is use of biologics does tend to protect, and as I said, whether it's to do with the biologics themselves or to do with control of disease activity, this is not able to be borne out in this particular study. This is looking at NAFLD, and worse clinical outcomes in IBD patients. Now, we know that IBD patients do have compared to non-IBD patients, do have an increased risk of NAFLD with fewer metabolic risk factors. Now, this is looking at a readmission database between 2016 and 2017, looked at patients with Crohn's disease and UC with or without NAFLD. It was propensity matched, and they based on the groups based on their metabolic risk factors. And what they looked at was a readmission rate and death, and then additional length of stay and additional cost of care. And these are shown on the right. In terms of the baseline characteristics above, they were similar between the different groups. And the readmission rate, death, the readmission rate, the length of stay, and the cost of care were higher in those patients that had NAFLD, both in Crohn's disease and ulcerative colitis, but there was no increase in death comparing both groups. And this looks at the IBD readmission, steroid readmission-free survival in the no NAFLD down the bottom, no NAFLD versus NAFLD for Crohn's disease and ulcerative colitis, really showing this both in graph form and in the tabulated form above. So it seems that NAFLD in itself or some of the non-metabolic risk factors linking IBD and NAFLD seem to in themselves cause worsened outcomes in patients with IBD and NAFLD. They weren't able to tell us, the degree of liver disease in terms of, degree of fibrosis, I should say. That wasn't told as part of this study. Hopefully it'll come out in the paper. This is the final slide for tonight. It's looking at work productivity loss and activity impairment. It's a registry which encompasses patients with psoriatic arthritis, psoriasis, Crohn's disease, osteocolitis, and looked at employed adults between 20 and 64 years of age between May 2017 and June 2020, and looked at work productivity and activity impairment, which is assessed by the WPAI score and includes absenteeism, presenteeism, work productivity loss, and activity impairment. And essentially, the first thing to say is that if you had worse disease activity, and this isn't your work productivity loss was worse, and you can see that if you look at the remission, mild, and severe disease activity across the different disease states, your work productivity loss was worse when you had more severe disease. That said, though, that psoriasis patients had more moderate to severe disease compared to patients with UC. So the vast majority of patients with UC, the greater proportion of UC and Crohn's disease patients were in remission compared to psoriatic arthritis and psoriasis patients. But despite this, there was greater work productivity loss in IBD patients compared to those patients with psoriasis. So the conclusion basically states is while the majority of study patients had low disease activity, they experienced a higher amount of work productivity loss and activity impairment compared to patients with psoriasis and psoriatic arthritis. I think we do need to be aware of this and track it and try and address this as well in our IBD patients, tease out why this is the case and then try and address it. because I do think it's, we do know, I don't think we really potentially, apart from controlling disease, actually try and address why that is. These are the take-home message. Miles has already said these today, just to recap from the 2 webinars, and thank you everybody for coming. Seaview study, diet and Crohn's disease, and checkpoint inhibitor colitis. And I think one of the other things also was around visceral fat, Miles. I think that was also another take-home message we thought of, I think, in terms of the what we thought were the key sort of abstracts from this year.